So this evening, on behalf of Harvard Bookstore, I'm honored to welcome Unity Dow and Max Essex for a discussion about their book, Saturday is for Funerals. Saturday is for Funerals explores the HIV/AIDS epidemic in Botswana. This book not only looks into the lives of people living in the midst of an epidemic, but also provides a detailed analysis of how a society successfully tackles a major health crisis and provides a model for other nations. Esteemed novelist and Dr. Abraham Verghese hails Saturday is for Funerals for its ability to, quote, bring to life the utterly unique stories of the people in Botswana, universal stories of struggle, suffering, and redemption with which we can all identify. The partnership of Dow and Essex, storyteller and scientist, results in a precious alchemy, a book that is engrossing, transforming, and an important addition to the canon of literature of HIV. Unity Dow is a judge, human rights activist, and writer from Botswana. She has written 4 novels, including Juggling Truths and The Heavens May Fall. Her fiction focuses on the tension between Western and traditional African values, gender issues, and issues of global poverty. As a lawyer, she earned acclaim for her stances on women's rights and was the first woman to serve on Botswana's High Court. Earlier this year, she was sworn as Justice of the Interim Constitutional Court of Kenya. Max Essex is Lasker Professor of Health Sciences at Harvard University, Chair of the Harvard School of Public Health AIDS Initiative, and the Chair of the Botswana Harvard AIDS Institute in Botswana. He's been involved in AIDS research for over 2 decades, holds 9 honorary doctorates, and has received numerous accolades, including the Lasker Award, the highest medical research award given in the United States. He's published over 500 papers and 11 books, including 2 editions of AIDS in Africa. Ladies and gentlemen, we're so honored to have Max Essex and Unity Dow with us tonight. Please join me in welcoming them both.
Well, thank you very much. Thank you all for coming. Thank you, Heather Gain, for arranging this. Thank you, Martha Henry and Molly Atlas, for helping to arrange it, I guess. And we're happy you came. We're even happier if you read the book, which I think you will after this. And I should begin maybe by talking a little bit how the book came to be, as opposed to just some of the detail in it. I'm going to ask Unity to do some of that. The book came to be because we sort of recognized that there was a need to fuse together the despair and agony and sometimes enlightenment and occasionally joy about this horrible tragedy of HIV/AIDS in Africa, especially Southern Africa, where some of you may not know it's much worse than everywhere else in the world, including the rest of Africa. Rates in Southern Africa are 4 or 5-fold higher than in other parts of Africa that you often hear more about, such as Uganda or Central Africa, former Zaire, Congo, etc. So it's a very, very serious problem there. And one of the things I do is to teach a class here across the street to undergraduates. And it's always a challenge to get them to appreciate both the science of AIDS, especially AIDS in Africa, and the human tragedy. And I thought the best way we might approach that would be to fuse together actual stories that help illustrate the problems of transmission, of treatment, of death of orphans, of transmission from mothers to their children, of problems when treatment doesn't work and drug resistance occurs, problems in making a vaccine, problems. So I wanted to find somebody who could do that very well, and it was obvious that the one who could do it very well was Unity. I'm sure some of you have read her earlier books, and as opposed to probably the only other author you've heard about who writes about Botswana, Alexander McCall Smith, was a friend of both of ours, but nonetheless, he always writes about light topics and sort of easy to read things. Unity, on the other hand, writes about depressing things, not only AIDS. And they're not always depressing, but that was really what we needed for this. So it seemed pretty obvious that she was the one that could best do this and somehow keep people interested, and then hopefully they'd read the end of the chapters and learn a little bit about the science of the problem. So we had this idea 2 or 3 years ago. Went to a friend in Boston, Esmond Harmsworth, who some of you might know, who is actually a lawyer for authors. And that wasn't why we went to him. He's a personal friend, which was really the reason we went to him. And we said, look, we've got this idea for a book. And Unity, who's this great novelist, will write these stories, and then I'll spell out what they are in science. And he said, but wait, she's doing fiction and you're doing nonfiction. There's no shelf in the store for half fiction and half nonfiction. You know, so one of you has to switch. And she said, why would I write fiction anyway for this? I know so many people, I know so many difficult situations that I can certainly write nonfiction. So it is indeed nonfiction, and only the names have been changed. And I would just close by telling you very, very briefly about some of the exciting progress that's going on in Botswana. And not just exciting progress in relation to acceptance of the people of their difficult dilemma, but exciting progress in research. And for example, we now have, for the last few months, techniques to essentially stop breastfeeding transmission of HIV, which we didn't have before. That's very important because infants faced in the past in sub-Saharan Africa with a choice of either breastfeeding and getting HIV or not breastfeeding and taking formula and getting diarrheal and respiratory diseases and dying from those because they get dirty water or inadequate protection of other types. So we think that's a step of real progress. And secondly, as an extension of that, and hopefully how we can learn from that, we started a new project in the town of Machuti, which is the town where Unity comes from. And that actually wasn't the reason we selected it, although some of her contacts with Chief Kafela, who's the tribal leader of that district, certainly made a big difference in our selection of Machuti. We're now trying to extrapolate what we learned about how to protect infants from infection from their mothers to prevent transmission between adults. Heterosexual transmission between adults who are desperate to have children, as most adults are. And we believe we've got a good design. We've just started the project in the last few months. It will take 3 or 4 years before we have results. But at least I am optimistic, and Unity's helping me. I think she's optimistic too. Of course, there are many other people in the project. Molly Pretorius Home, who's here, is involved in the project, and many others. So I would encourage you to read the book, to not think only about what horrible circumstances so many families had to go through and individuals had to go through in Botswana, but then at the end think of how progress has begun, and progress is now increasing incrementally so that we can, I think, look for generations in the future where AIDS will not be the devastating disease, even in Southern Africa, the way it is today. Thank you. Unity.
Thank you, Max. And thank you very much, all of you, for coming today. Of course, Max is right. I depress you in the book. But he uplifts you, because I think that I have met, I've not met anybody who is as optimistic about the future of, the HIV work in Africa as Max has been. So I think this book is not, I tell the stories of people living, loving, thriving, struggling with HIV/AIDS. But he responds, to that story by picking, kernels from those stories and building hope around them. I tell a story about how my mother sees the epidemic, and he tells a broader story about the science of epidemics and how he sees the possibilities of getting us getting out of this pickle. I tell stories, of a teenager, and we all know teenagers all over the world are really terrible people. No, we've all been teenagers, we know that. But and he posits, and of course, if you're a teenager with problems in Africa, it's not drugs that you're going to have problems with. It's going to be, early pregnancy and with the consequences of possible HIV infection. And he brings the science around that, the possibilities that could happen, but he also brings the hope, of what could possibly, where we could possibly succeed. So, for me, this, I say really, honestly, that sometimes I read the stories that I wrote myself, even, months later, and I sometimes cry because I know that it is the stories of people who actually live around me, and some of those people have since died. Some of those people have since, been helped. So it's a continuing stories that go way beyond the pages. Long after you close the book, those people's lives will still be there. Those people's lives, will still be, affected, impacted on by HIV/AIDS. So often people say, "Who is this book for?" I think it's for everybody. It's everybody who cares about humanity. It's everybody who knows that in every story there's a story about themselves. I don't believe that anybody can read this book, any aspect of it, and not see a piece of themselves, a piece of their family, a piece of people they know and they love. Even if that piece they see has nothing to do with AIDS, but it's got about struggles, it's got about disease, it's about health or lack of health, about life, love, and struggle. So. It's been really wonderful, collaborating, with Max. As he says, when he first came to me and suggested this, he says, I said yes. But of course I said yes. He's a professor from Harvard. He's a guy, he's someone who's been working HIV/AIDS in Botswana. I respect him, greatly. So of course I said yes, even before I was sure about what I was talking about. So only after he left, I said, is that really possible? But I knew that if he thought it was going to be possible, that he has filled me with so much hope in the last, 10 years that I've worked with him. I've worked with Harvard. And therefore, I knew a project that, he comes bearing has to be a good project. So I'm really, really excited about, the journey that we've traveled and together. And, I guess honored to have been asked. And I'm sure we've learned a lot from each other in the last, years that we've worked together. And I'm really so happy that you are here to be part of the celebration of that journey. Thank you very much.
Speak to one of the narratives in your. Give us an example of one of the narratives in your book. On the microphone, if you would.
Then I'll read it. Oops. I'll read from just a few paragraphs from the first chapter in the book, page 5. Which is titled A Family of Funerals. And to that title, Max responds, The Epidemic. So this particular story gives a personal view of somebody living within the epidemic. And then the second part of the chapter, is Max now giving you an idea what is an epidemic and comparing with early epidemics, and why this particular epidemic is special. My parents are in their 70s, and this makes them the senior members of their respective extended families. Hardly a wedding or a funeral in the neighborhood or the family can take place without their attendance. My mother says that The good thing about weddings is that they can be planned. Funerals usually cannot, as they cannot be sure when death will strike. But with the climbing rate of AIDS deaths, funerals are taking up every Saturday, squeezing weddings out of the agenda altogether. Nature has gone crazy, she says. There has always been a balance between death and birth, but no more. We are burying babies with their parents. How can there be a future, she says. It is a Saturday in 2007, and my mother has not been to a funeral in 2 weeks. She's grateful for the respite. She whips out 3 funeral programs. Here, and she says, here, you may not have heard about these deaths. She goes on. She explains how she was related to the 3 deceased persons. One was related to her through her great-great-grandmother, and the other in some equally distant way. She does not think their relations were so distant, and she rebukes me for not taking blood relations seriously. She keeps funeral programs like many other people because so many people are dying that it is difficult to keep up. If you have not seen someone for a while and you meet their mother, you are afraid to ask after them. Perhaps they have died and you have not heard about them. It was not like this before, she says. You must remember people's children and be sure to ask after them. How can you ask about people who may be dead? I remind her that things have improved. She has not been to a funeral in 2 full weeks. My youngest brother, who lives in a home with her parents, pipes up that he has not dug a grave in 3 weeks. He too is grateful for the break. He cannot remember a Friday night in 2004 or 2005 that he did not dig a grave. No, a week during those years that he did not ride a truck to collect firewood for some funeral or another. For my mother, the funeral of a relative or a neighbor, and in a village setting, these terms are defined very liberally, demands attendance at every evening prayers, from the time of the person's death to the date of the funeral, which would typically be the next Saturday at 6 a.m. in the morning, as well as an overnight vigil the night before the funeral. In the case of a particularly close relative, she must spend nights at the home of the deceased person with other senior members of the family. My mother is generally dissatisfied by the funeral attendance of her children. She feels we do not attend enough funerals. Who is going to bury me, she says, when I'm dead, if my children do not bury others? My sister jokes that we are big in our family, as a family, to bury our own. My mother fails to appreciate the humor. I'm going to be eaten by dogs, the way you carry on. My funeral will be the talk of the village. She exaggerates, but she is correct. Since age started claiming lives with such regularity that some families have had to quickly bury one family member during the week to make way for another over the weekend, we have not been able to keep up with funeral demands. And a typical sanction for punishing a family whose members do not attend funerals of others is for a crowd to attend the funeral in that family but do not eat the food provided. It is considered the height of insult to be left with pots of food and no one to share them with. And my mother lives in fear of this ultimate insult. My brother tries to mollify her. But I attend funerals. I dig graves all the time. You should not worry. Yes, at least dogs will not eat my feet. But who will eat with you afterwards? Your brothers never attend funerals. Funerals are exhausting undertakings. For the closest family, neighbors, and relatives, during the days leading to the funeral, they have to brew tea, bake the papata bread, cook sorghum porridge with spinach or cabbage, and perhaps goat or meat. For the close male relatives and neighbors, the work involved during the days before the funeral includes collecting firewood and killing, skinning, and preparing the goat or cow, if the family can afford such a luxury. The night before the funeral is particularly busy. Men dig the grave and cook the meat. Women cook the sorghum porridge, maize porridge, and samp that must be served at every funeral, while bringing tea for everyone throughout an overnight vigil of singing and preaching. And by 6 a.m., the food is ready and the funeral proper begins. I will end here. So that is a piece from Saturdays for Funerals. Thank you. Yeah. Actually, that is exactly what the title is trying to say. You know, that traditionally, only Saturdays are for funerals. But there have been so many deaths, you know, so the statement of fact is Saturdays are for funerals. but also the question whether every Saturday should be for funerals. And as a matter of fact, the epidemic has done is that they claimed all Saturdays and spilled onto other days as well. So it's really a play on that whole idea, that is funerals are claiming even other days other than Saturdays. And in fact, as a matter of fact, during that time, it's changed quite a bit since drugs started to work. Is that graves at home are dug only at night. As growing up, I've never seen anybody dig a grave because they dug by young men at night. So in the morning you find the grave is already done. It's done. But now it was getting so commonplace that you actually saw people during the day digging grave, which is like the height of shock. So there were so many deaths that actually rituals started to change as a result of that, of the demand on people and time. Yeah. Everybody would know what the cause of death was, but it would not be named. I mean, the monster in the room would not be named at all. And of course, with HIV/AIDS, AIDS doesn't kill you as such. You are killed by some other, like the TB or, so it's easy to say they died of TB. It's easy to say, they died of diarrhea. It's easy to name something else and avoid, really what is underlying, why a 25-year-old, why a 30-year-old, why a 35-year-old is dying, in the prime of their lives. Is that changing? It's unlikely that you're going to hear at a funeral, because how funerals go at home is like this. At the end of the funeral, then there's an announcement as what actually killed the person. So it's so people will say this person died after a long illness, after diarrhea, or this people died, after coughing. So even if it was cancer, even if it was, high blood pressure, it's unlikely that people would actually, they're more name the symptoms as opposed to maybe the medical, what we find in a medical certificate, So, but the reality of AIDS, you're right. Even in my workplace, if somebody died, then a note is passed around for people to contribute some money to the funeral, and they were becoming so many that people could not keep up, especially in those years of 2004, 2005, and really one hopes that with the work of Harvard and other researchers that this tide can begin, to change. Yeah.
I've heard the good news that breastfeeding transmission of HIV/AIDS has been arrested, or ways have been found to prevent it. But it makes me wonder, is it medication that's being used? Because women breastfeeding typically are urged not to take medications, or friends of mine, caffeine or alcohol and so forth. So I'm just wondering what the, obviously it could be a trade-off also. I don't know how much you can respond to that.
Yes, it is medication, but the approach involves starting the medication late enough during gestation so that any significant danger for birth defects in the fetus and the child to be born are essentially nil, and continue the use of the drugs in the mother while she is breastfeeding. And then it's interesting to see how it works, because it doesn't just work because the drugs act to decrease the levels of virus in the mother's milk. They act in part because the drugs flow through the milk into the infant and protect the infant in a prophylactic type of way, so that the infant then becomes a little bit like someone who had a needle stick accident from an HIV positive patient and wanted to protect themselves from the virus getting started in the body, so they take drugs right away. But the dosing, if we can call it that happens through breastfeeding, is actually a very efficient way of keeping up the correct levels of drug in the infant, as well as reducing, of course, the level of virus in the mother. Botswana has had a very good governmental leadership, not only in the court, but in the executive branch as well. And the three, now fourth, just started as president, but the three who have been president in the past have all been very responsible, democratic-type leaders that have cared a lot about the country and haven't sought to make the country's fortunes their own. And the president who just finished recently, President Festus Mogai, initiated a program that he called Opt Out, which Unity talked about on a talk earlier today, which was really the first in the world approach to getting people to find out their status and get tested. And this was an approach where when someone goes into a clinic or hospital for any reason, from a school health examination to automobile accident or vaccination, they're asked if they refuse to have an HIV test, not if they like one or something, but do you refuse to, putting the reciprocal kind of slant on the question so that you will look a little bit stigmatized if you refuse, maybe. I don't want to get into the ethics of that, which was challenged for a while. But that has in fact resulted in a situation where the numbers I've heard last are that something like 56 or 58% of all adults in Botswana know their status, whether they're infected or not. And you think of that with respect to any other country in the world, including the US and other countries in Africa, and it's far, far higher. It's also stated by the World Health Organization, for example, that 85 to 88% of HIV-positive pregnant women get these drug chemoprophylaxis interventions to prevent transmission to their infants. And that 85 or 90% of HIV AIDS patients get drugs to prevent their death. And that's far, far higher than other countries in Africa. I mean, some of them are very low, some of them coming up. Even countries you've heard about, like Uganda, where treatment has been in place for a while, it's nowhere near that high. So it is true that the government of Botswana has been tremendously successful in mounting such programs and helping the people who are infected with HIV/AIDS. And I think they deserve a lot of credit for that. I mean, that's not what we're doing as researchers. That's something the government made a decision to do. And I think that's very important.
And the local leaders also bought into that, right?
Yes. In fact, we mentioned earlier on that we just started this new project in Machudi to see if we can use some of these lessons to try to prevent transmission between adults. And in that situation, we've been talking about, we've started it recently, but we've been talking about it for about 2 years, and about a year and a half ago, so Chief Kafela, who's the tribal leader for that district of Machudi and a friend of Unity's, when he was inaugurated as tribal leader and dressed up in the leopard skin and all this sort of stuff, and gave his speech, he said that one of his goals was to start a new research project with Harvard on prevention of HIV/AIDS infection. So there's a lot of encouragement. There's a progressive attitude. Now, the other thing you have to remember, though, is that with the successful treatment of AIDS in sick people so they don't die, you're increasing the total number of people who are HIV infected, even if you significantly decrease the rate of new infections. Because if you've cut by 75 or 80% the death rate, and you haven't cut by 75 or 80% the new infection rate, if you've only cut that by 50%, you'll increase the total number of people infected because those infected live longer. So the challenge then becomes, how do you present these numbers to people who are looking at the total fraction of your population that's HIV infected and say, gee, Botswana is still very high, they're 25%. Where's the progress? Progress is in the healthy people and a significant drop in incidence of new infections. But it's going to be a long, long time before there's a significant drop in prevalence of the total number of people infected.
Have I changed as a result of my involvement with... I mean, the interesting thing is that I've been involved with Harvard as long as I've been a judge, actually, as I remember. Yeah. I remember the first staff member you sent to Botswana, I met. And since then, I've always been interested in the work of Harvard. And I've seen, the tremendous, progress that has been made because of that collaboration. So has it changed me? It has to. I mean, this epidemic has to change you. I mean, it has to change the way in which you... I know that it's made me more likely to get into your business, even though I have normally you think, he looks ill, but that's not, what right do I have to go and ask this gentleman, what's wrong with you? But one thing about the epidemic, made me, changed me in terms of being not reluctant to actually get into somebody's business and to say, look, I think you look ill, and I think, you want to do something about it. And even if they're reluctant to talk. And also what I've learned is that people who are infected, who are ill, want to talk because they feel that there's so much silence, so much dancing around them, that if you just ask that question, have you been tested? There's like a relief that somebody is naming, the problem. So, yeah.
It certainly has changed my perspective on how to do research and which research to do. When I was initially trained as a virologist, and in years past, it seemed totally satisfying and indeed often the most challenging if you could just unravel the code of a given virus and how it replicated or grew. As time went on and I saw the agony of disease, I decided that others could do that, and it was even more important to try to find which interventions might be useful to prevent infection, like vaccines. And I spent a lot of time, still spend a little time on vaccine research. And then as vaccine research was a little less rewarding than many of us had hoped, I decided that we needed something sooner. And all these people were dying, and you needed to do research on something that would make a difference sooner than 10 or 20 years from now. So I found myself doing more and more research related to both treatment and prevention of infection using drugs. And I suppose I could say that that's one of the ways it has changed my outlook on which research seems most important to do. The other way of looking at it is, I've been in research for a long time, and at my age, if you're in a field where the result isn't going to come for 20, 30 years, it's a little less exciting if you're not going to be around in 20 or 30 years to see it. So I might be around to see it, but you get the point, I think.
And gender and HIV/AIDS, and in terms of, I guess in so many different ways. I mean, I think, first of all, even earlier on, a lot of the education, on HIV/AIDS seemed to be targeted at women, and seemed to be reaching women more than we're reaching men. And also, the people who seem to be testing, seem to be more women than men testing. One of the reasons, of course, is that women take children, women become pregnant, and therefore they get caught, within the healthcare system, and therefore they have greater access or greater contact, with the healthcare system than men, and they take children to babies and children back to hospitals or health clinics. So they continue to have more, contact with the healthcare system. As a result, they become really the first, frontal in terms of HIV/AIDS work. And then, of course, the mother-child transmission. I know there were a lot of discussion that it should not be about mother and child transmission, be parent and child. So the question was, how do we include, how do we, make sure that we don't focus only on women and see the greater society or even their partners. But I think with this opt-out program, you find that now that imbalance is beginning to shift. That almost it's not, the focus not only on women, and the respondents are not only women. But there's no doubt that, there's gender dynamics, from all kinds of respects, and just in terms of this susceptibility to being, infected between men and women, for example, and, how, so there's so many, and I guess so many issues, and a lot of work has been done recently of trying to get men involved, and I think now there's even like a male sector on HIV/AIDS. There's a lot of work, especially with I think the American Embassy in Botswana has worked a lot trying to use sport and target boys and men, to around education on HIV/AIDS, try to make them active participants in the fight against HIV/AIDS, and also in sending out messages. So there really has been a realization that you need different strategies if you're going to reach to reach both genders, and also if you're going to reach partners. And the recent messages also is really about partnership, about relationships. So you see a lot of messages either on television, on billboards. It's about partners, and how as partners, you have to deal with this problem. And there's a very great one where there's a great skit on television every evening, where this husband and wife, she's reading this little pamphlet about HIV/AIDS. He comes into the room, so she puts it under, sits on it. And then the following morning she goes to test. And as she's leaving the testing room, he's leaving, another testing room, and they're shocked to see each other there, because they didn't discuss this. So really trying to say, if you had discussed it before, you don't have to meet there and be surprised that you are, both of you are actually concerned about this issue. So, but I'm sure it's much more nuanced than I'm putting it. Yeah.
Professor Essex, thank you so much for joining us today.
Thank you.